Good morning. This is Median Ali. I'm going to present in this lecture a quick review of coronavirus and COVID-19 diagnosis, treatment, prevention, and other aspects of care. Before 2002, we were aware of only 4 types of coronavirus that affect a human. These 4 types are listed here. One example is the HQU1. It's illustrated in this picture. These 4 viruses, they usually cause common cold symptoms or syndrome. Most of the cases very benign, and very rarely they have complications. Now, until recently, we did not know there may be cross-reactivity, but there are some reports which are suggestive that infection with these viruses may create some T-cell immunity to the COVID-19. We're not sure yet about this. I will explain it later in this lecture. And then in 2002, we added the SARS. In 2012, we added the MERS. And then finally in late 2019, early 2020, we added the SARS-CoV-19. These last 3 jumped from animal to human, from bat to human through intermediate host. To understand COVID-19, we need to go back a little bit, maybe a couple of decades, and talk about the first coronavirus transmission from animal to human that was reported with SARS, which is severe acute respiratory syndrome, was reported first in China in 2002. And it was also traced to bats. The other one was the Middle East respiratory syndrome, or MERS, M-E-R-S, and that was identified first in Saudi Arabia in 2012. Coronaviruses actually are a family of RNA viruses. To understand better the structure, you have the RNA inside the genetic material, then you have the envelope, then you have the membrane, and you have different proteins. Some of them are very vital for the virus, especially when it comes to entering the cell and to maintain also the shape of the virus. You have the nucleocapsid protein N, which bound to the RNA genome to make up the nucleocapsid. You have the spike protein, or S protein, which is really, really important when it comes to enter the human cells with COVID-19. And without that S spike, the virus cannot attach to the ACE2 receptors on the human cell or on the pulmonary cell especially. So the virus may not be as infectious if we can find a way to neutralize this S protein. And then you have the envelope protein E, which interacts with the M protein to form the viral envelope. So between the E and M protein, they are very vital to form the envelope part of the virus. And then the M protein also is a central organizer of the assembly of the virus and also determines the shape of the viral envelope. So a lot of studies are done about these proteins, whether when we study the antibodies, the monoclonal antibodies, or when it comes to some of the vaccination, especially mRNA vaccines. So this is another demonstration of the viral. You used to have the genetic material inside right here. You have the protein shell around that. Then you have the envelope here, and then you have on the top the protein spikes. And that what actually gives the virus its name, the corona. This looks like a crown or like the sun. Um, so going back to SARS, again, it was reported in 2003 in Asia, and I think by July 2004, it was gone from the world, which is great. Um, the total cases reported a little bit above 8,000 cases. Number of death was about 774, and fatality rate was about 10%. Um, uh, Unfortunately, also like what we see with COVID-19, a lot of healthcare workers got infected. But after July, there were no cases reported. And there are a lot of theories about why it didn't come back. Um, the, some of the explanations provided, maybe there were not a lot of pre-symptomatic or asymptomatic cases. So when you get sick with SARS, most of these patients were very sick and they did not interact with other people. They were isolated. They did not take airplanes. They did not travel to different parts of the world. Others, they say it has to do with the affinity of the virus to the receptors on the host cells. Um, but really, we don't have a good explanation why that virus, which was very severe, again, fatality rate 10%, did not become a pandemic at that time. MERS is also, most of the cases came from camel to human. Some cases reported from human to human. A number of cases less than 2,500. There are still cases reported every year, but very minimal number. The fatality rate is also very high. So a lot of these patients, when they get sick, they go to the hospital or they die. They don't really like go into the community. So and the human-to-human transmission was not as severe, obviously, as SARS or even as COVID-19. So as you guys know, US was affected really badly back in March and April. We took a lot of measures. We were late, from action standpoint or reaction standpoint. We didn't do as good job in testing, so we really did not figure out that we had a problem until relatively late. But the measures we took start to really produce results when we were able to flatten the curve. We were able to come down on the number of cases. We got things relatively under control, especially in the Northeast. And then the CDC came with guidelines. We advised, okay, you can reopen, but you have to do it gradually, steps according to the guidelines. You're going to have to follow the number of cases, and if there is decline for 2 weeks, maybe you can start to open in multiple phases. Well, we didn't do that. And we did not, we opened the economy right away. We did not follow any guidelines in most part of the states, maybe except for New York, New Jersey, and Connecticut. And then what we did also, we did not do enough testing and we did not do contact tracing. So we know the results. After Memorial Day, or somewhere here, we start having this huge surge of cases. And now, we're way ahead of, we're above 4 million cases, and obviously going in the wrong direction, especially in states like Florida, Texas, and Arizona. If you look also at countries like Brazil, which lacked really any kind of national leadership when it comes to fighting the pandemic. India, unfortunately, they have a lot of cases right now. South America also is going very difficult time. So I'm gonna just go some activities and give you a little bit of risk assessment. For example, a low risk if you're playing golf, dining outdoors, you're on the beach, playing tennis, outdoor exercise. Medium risk, staying at hotel, getting a haircut, you're in the casino, exercise at gym, you kids at playground, and then high risk, definitely high risk, if you're at an indoor party, indoor bar, nightclub, sports stadium, church, buffet, amusement park, uh, and if you don't wear a face mask on routine basis, that would put you at high risk as well. One of the things about COVID-19 is um, it did show us that we are, as a society, um, not doing good job in delivering healthcare to large portions of our communities. And it also reveals the social injustice. In general, people with the poor socioeconomic status, they have high risk of having serious illness or even dying from the illness. As you can see here, the increased risk for Black, Asian, minority ethnic group compared with white. As you can see, 2.7 for Black compared with white. You see here with Indian is about 1.8, and with mixed about 1.2 to 1.3. The other obviously important factor is having comorbid conditions for serious illness. As you can see, cardiovascular disease has a much higher risk, 10%, and diabetes 7%, high blood pressure is also there with about 6%. This is from Chinese study, and I think it's still probably valid in other subsequent studies. Majority of infections are mild, about 80.9%. But the emphasis about mild, that means you really did not go to the hospital, or you may went to the ER and was sent home, but doesn't mean the disease was really particularly mild. A lot of these people actually suffered from febrile illness, severe symptoms, disabling symptoms almost, for about 3 weeks or longer. So even if you are young and you feel like, oh, I don't care, I'm going to get a mild disease and get immunity, well, this is not going to be without paying heavy price, and there is no guarantee that you may not, progress to a more severe disease. 13.8% are severe cases that we saw in the hospital, and only 4.7 of these are critical, requiring intensive care unit admissions. So when people compare, COVID-19 with regular seasonal flu and claim without really evidence that it's another flu, obviously they are wrong. And even though we really don't know exact fatality rate, we know that COVID-19 it's way much more contagious than seasonal flu. Each patient with seasonal flu can infect maybe 1 to 1.5 people, while COVID-19 goes between 1.5 to 3.5, with fatality rate anywhere between 0.7 to 3.4, compared with the seasonal flu, which much less, about maybe 0.1%. And comparing that to MERS, which was around 33%, Ebola about 50%, smallpox about 30%. So the only one that is more contagious than COVID-19 is measles. I know, like, as you guys know, we eradicated smallpox, but measles, at least we have vaccine, and we still have people dying from that, but in limited places and limited areas. The difference in gender is also a big factor. Um, Men in general, they have a higher risk of getting more severe disease and death. As you guys can see, 63% men compared to 37% women. Some scientists believe the advantage lies in the X chromosome, which carries genes linked to immune function. And because women have two of them compared with men who have only one, also the hormonal role, the role of estrogen and progesterone, which can carry some more immunity for women, especially pre-menopause. And some other people propose that women in general actually follow health guidelines better than men. And I think we all agree to some degree that may be the truth. Incubation period for COVID-19 can go up to 14 days, but the median time is about 4 to 5 days from exposure to symptoms onset. One study reported that about 97.5% with COVID-19 who develop symptoms will do that within the first 11.5 days. So really very unlikely after 11 days to that you're going to have COVID-19 if you got exposed to it. During this period, also known as pre-symptomatic period, some infected persons can be contagious. So there are a couple of days before you have symptoms. This is a period we call pre-symptomatic. A lot of these patients can be infectious and can spread the disease. This is the incubation period for COVID-19 and compared with other diseases. As you can see, Ebola has a very long incubation period. MERS and SARS, they have long one. COVID-19 is about an average probably 5 to 7 days, but most of them they are below 11 days up to 14 days. Compared with the seasonal flu, which most patients present within a couple of days. Norovirus couple of days, pneumonia maybe 1 to 3 days. These are the classic symptoms that we see with COVID-19. There is one study that showed fever, cough, and shortness of breath is, really common in these patients to have one of these symptoms. So if you really start to have these symptoms, you really need to stay home. You really need to maybe call your primary care physician, be tested, and isolate yourself from your household and from your community. Fever reported in about 83 to 99%, cough in 59 to 82%, shortness of breath 31 to 40%. My observation about shortness of breath, most of these patients initially they may not have it. Some patients may have mild symptoms initially, and then as they go into day 7 to 9 after onset of symptoms, they start to have shortness of breath and they may present to the hospital with this symptom. In addition to the typical symptoms that we talked about, there are other atypical presentations that we see in elderly and people with comorbid conditions, such as headaches, confusion, runny nose, vomiting, and diarrhea. Fever actually can be absent in this patient. When they come to the hospital, only 44% reported fever, but throughout the hospital stay, they would have fever in about 89%. The GI symptoms may come prior to having the fever or lower respiratory symptoms, and sometimes they may not come. Loss of the ability to smell and taste, what we call anosmia and ageusia, have been described as well, and actually we see it now more and more as we have more young people actually presenting with these symptoms, and sometimes it could be actually the only symptom they have. So immunity and risk for reinfection. So let's talk about the what you call immunity passport. As we know that COVID-19 is not just illness, it's a kind of economic disaster that the world is facing right now. The implications are unbelievable, and I think what we're going to see is much worse picture as we get closer to the end of the year. Um, so a lot of nations and politicians and others looking into what you call like immunity passport. Is there a way that we can get part of population that were exposed, they had the disease, or they were asymptomatic, and they got antibodies? Is that good enough? Can they go back to work, be on the front line, and etc.? Well, there is really, until now, there's no evidence about whether we will have enough antibodies and whether they are effective antibodies to prevent further infection or provide what you call immunity passport. We have a lot of problems with the lab test that we do now for antibodies for SARS-CoV-2 because some of these antibodies are, for one, not FDA approved. They may not even check the right antibodies for COVID-19. And they may actually have a cross-reactivity with other human coronaviruses. Um, the other problem also the fact that the antibody testing only gives you, if you have antibodies, doesn't give you a quantity and doesn't also tell you if they are effective. So can you use antibodies to make a diagnosis? Of course not. So as you can see in this blue line here is the virus, the test, if you do the PCR test. You can see here the test is positive here, the high positivity rate in the couple of days before the illness and then a few days after the illness. And then it goes down until probably most people are negative by day 28. Now, the IgM, it's the first antibody to start, usually day number 5, peaks at almost 14 days and disappears in 40 days. And then IgG start in 14 days after the onset of the symptoms, and then peaks around 28 between 21 to 28 days, and then start to decline. And there are reports now that few months after the disease, especially for asymptomatic or less sick patients, that these antibodies would disappear to level that is undetectable in a couple of months. So if you test the antibody here, for example, in day 14, you may actually be still infected. You may be still contagious and you think, oh, I have the antibodies. You have IgG, you have IgM, but you may actually, if you test yourself for the virus, you may be still having the virus itself. If you test yourself here, you may not have the antibodies, but you may still have the virus. And if you test yourself here, okay, that's good that you have the IgG antibodies and some IgM, you don't have the virus. So it really depends on many factors and on the time from the onset of the symptoms, whether these antibodies are helpful or not. I think, in my opinion, most of these antibodies so far helpful in epidemiologic studies. So these are some of the scenarios that I included in this situation. So the PCR is positive, IgG, IgM are negative. This is the period of infection. They could have 3 of them positive, which is in the active phase of infection. And if you have only IgG, that's probably recovery phase. So the value again of the antibodies is mostly for epidemiologic studies. If you really need to know how spread the disease, like the herd immunity and other epidemiologic studies. I don't think it is a good utility for diagnosis. As I said, depending on the time, it may give you or doesn't give you the right information. And as I said, it only gives you whether you have IgG, IgM. It does not tell you if you are really immune. When it comes to herd immunity, you need to have enough people immune to a disease to make its spread unlikely. So the entire community is protected. Obviously, not everyone would be immune, but the number of people that are immune are enough to prevent the spread of the virus. That herd immunity is usually achieved by the vaccination, but can also occur through a natural infection. Now we know that we have a high proportion of asymptomatic or mild infection, about 80%. And unfortunately, I don't think we have a clear understanding of the real number of cases and the real spread of the virus. So we really cannot predict the infection fatality ratio. I think the serological detection of the antibodies can help us in the future when it becomes more widely available and more reliable in understanding the real spread of the virus and also the fatality rate. Now, there are multiple antibody studies. What we understand is from these studies that most of the population appear to have remained unexposed to SARS-CoV-2, even in the areas with widespread virus circulation. There was a Spanish study showed anywhere between 5 to 10% antibodies, even in the cities like Madrid, where they have a high prevalence of the disease. Now remember, the serologic study only provide information about the previous exposure, not the immunity, as no neutralizing antibodies are measured. So we're hoping it will produce immunity, but we do not know that for fact. We also do not know what titer of neutralizing antibodies would protect recovered patients from secondary infection, or if non-neutralizing antibodies could also contribute to the protection. So there are multiple factors here. One, we don't know the titer, we don't know the type of antibodies, we don't know if there are other antibodies, we don't know also if there are other ways that the immune system, the body, will be protected. So even if the antibodies rate is going down, maybe you have a memory cell, B cell, other type of immunity and a recall system in the body that would actually prevent the reinfection. That part is still unknown. So far what we know about immunity after SARS-CoV-2, it is incomplete and temporary, lasting only several months to a few years. We don't know for sure for how long. We don't know how protective it is. Hopefully we'll have more information in the months to come. Now we know a subset of asymptomatic SARS-CoV-2 cases shows a lower antibody response and titer that wane quickly. So the less symptomatic with the disease, the less antibodies you're going to have, and obviously your antibodies will disappear quicker. Some studies showed that these antibodies go to undetectable level within 2 months. So any proposed approach to achieve herd immunity through natural infection is not only highly unethical, but also unachievable. And we know that that good example actually is in Sweden, where they were hoping for herd immunity, so they did not close the economy, they did not do really reliable social distancing measures, and their antibodies, like serology testing, showed only 7.5% of the population were exposed. So that's, by all means, that's not enough to achieve herd immunity. Now, it's not all bad news when it comes to immunity from COVID-19. Cell-mediated immunity is gaining more attention actually new study published in journal Nature. In this study, they analyzed blood samples from about 18 COVID-19 patients aged between 21 to 81, and also they got samples from healthy donors aged 20 to 64. The study was based in Germany, and they found that T cells reactive to the coronavirus were detected in 83% of COVID-19 patients and in 35% of healthy donors. So there are people who never exposed to COVID-19, never had the disease, and yet they do have some T cells that are reacting to COVID-19. This obviously the explanation is not clear, but maybe exposure to other type of coronavirus, the one we talked about earlier, maybe this would have some impact on creating some T cell immunity to COVID-19. That's something need to be determined. We're not sure about that. Some people go further and they say, well, maybe that's the reason kids and young adults don't have as bad disease, because they have more of these T cells from previous exposure, and they are readily available, and that's the reason they don't get as sick. Again, that's something we need to study and confirm. Let's talk about the concept of pre-symptomatic. So people in the pre-symptomatic stage are highly contagious with COVID-19. Actually, the peak of viral shedding occurs right before symptoms develop and immediately after, when the symptoms are still mild. So that is important on many levels. One is obviously that may be responsible to spread the disease quickly and make it very contagious, even if the patient, even for not the patients who don't expose any symptoms. And that what makes masks are critical to prevent the disease. It's very important that everyone behave as if he has the disease, because you could actually have the disease. And also the other important part is the speed of having the test results. So if I'm gonna, let's say I have a little bit of cough and I feel like maybe I have the disease, but I'm not very sick, to the point that I feel I cannot do my work, interact with others. So, and then I say, okay, I'm gonna have the test, and then the test comes back 5 days. Now, during these 5 days, I probably infected many people. So for people who are pre-symptomatic or asymptomatic, or for people who have a mild symptoms, it's really important to have a test that is reliable and that the results comes within less than 24 hours. The other important part about that is when you are planning to have elective surgeries for patients who test positive for COVID-19 without symptoms. Actually, we have data now that if you intubate someone for surgery in their pre-symptomatic stage, we may end up doing them harm, and they actually may have worse surgical and respiratory outcome. So now we test all the patients electively prior to their surgery, and if they test positive, obviously we decline, we postpone their surgery. That's really important. Now, what about asymptomatic? There was, kind of controversy about that, but I really think based on multiple studies now, I don't think there is much of controversy. We know now for sure that asymptomatic cases, about 40% of people infected with COVID-19 do not have any symptoms. And people under age 20, actually half of them, are half as likely to contract COVID-19 than the rest of the population. There was one person actually went to China and was able to infect, responsible to infect 71 other individuals in her community without experiencing any symptoms of the virus itself. Now, the other important factor when we talk about obviously school opening, only 21% between age 10 to 19 were likely to show symptoms compared to about 69% over age 70. So it's important on many levels. So if you are less than 20 years old, you're less likely to have to acquire the illness. But the problem also, a lot of this age group between especially 10 to 19, they don't show symptoms even if they have the virus. Now, it's a good news that they are not as symptomatic, they are not that sick, but how about if they catch this infection, they bring it to their parents, their grandparents, teachers, staff in the school. So that's where all this controversy about opening the school, what's the best way to open the school safely. Impact of age, I think by now we know that the older you are, the more likely to have severe disease, unfortunately, the more likely to die. Median age is actually 49 to 56, although the recent spread in the United States, actually that age dropped down. We, in the second wave, or maybe the second surge of the disease, we actually saw more younger age. So that number is shifting down. The hospitalization rate for COVID-19 also increased with age, and older age is understand the impact of age, and the fatality rate is very important, because that may explain to some degree, of course it doesn't explain the whole picture, but why we have that variability in the death rate. For example, we have way much higher death rate in United States or in Italy compared with United Arab Emirates. In Italy, the number of people above age 65 is 23%, while in United Arab Emirates is about 3 to 4%. So they have a much lower death because they don't have very much of elderly population. Now that doesn't explain the whole picture, because Japan, for example, and Germany, they have also large elderly population, but they did a much better job. And there are obviously other factors. For example, obesity is not as common in Japan compared with the United States. So you take age, you add obesity, lifestyle, we have a lot, like 60% of population in the United States, they have to some degree high risk for or comorbid conditions. So that is a very high number. Now the other thing also, like preventive measures, use of mask, use of social distancing, adhering to healthcare recommendations was much higher, for example, in countries like Japan compared with Italy or United States of America. So people compare flu versus COVID-19, death rate and age and all of that. People say, oh, just a flu. Well, let's see if it's just a flu. So I want to go through different age groups. So if you really like, for a flu, if your age 18 to 49, your chance of dying from this virus is 0.02 compared with about 0.9 if you are in the in COVID-19, almost between 0.3 to 0.9. So it is much higher rate. It's more than tenfold higher rate. And sometimes for elderly, it's actually way much higher rate. For example, if you're age above 65, for flu, your risk of dying 0.83. For COVID-19 patients, you risk close to 20% or even more, 10 to 20% or even more if you're above age 85. So the problem right now for people who do not understand this is not a flu, there is much higher death rate, and we don't have a treatment for COVID-19, and we don't have vaccine. So there are many faults of how this is more lethal and more emergent, more important problem right now. Now, imagine if you have the two problems that to deal with in the fall and winter, and you can think about like what is waiting for us if we don't take really drastic measures. Unfortunately, we got hit very hard in United States with COVID-19. As you guys know now, we have more than 4 million cases um, around the country and multiple hotspots in Florida, Texas, and Arizona, some in California as well. Um, we actually number one country in the whole world right now, um, followed by Brazil with uh, more than 2,200,000 cases, 200,000 cases. India is getting close to 1,300,000 cases. Russia is about 793,000 cases. Um, if you look at the fertility rate, it's actually, even though we have more cases, the fertility rate is going down because more young people are infected now. So after the lockdown is over, the most people went back to work were actually more young and relatively healthier. A lot of elderly actually still not um, uh, or going to restaurants or engaging in the community, which is a good thing. But on the other hand, unfortunately, I think it's a matter of time before the young population going to infect their family, their mother and father, grandfather, and eventually we're going to see increased death. And we've been actually seeing some increased death in the last few days. So our fertility rate is 3.6. Again, I warn you about this number because really the real number is probably the fertility rate is going to go even farther down because a lot of people are asymptomatic, even though we're doing a lot of testing, but it's still, in my opinion, not enough. And it's very hard to know the fertility rate during the pandemic. It's actually when this is over, at some point we have to look back and maybe using serology testing and figure out really how many people were infected for real. And also the fertility rate. So our fertility rate is about 3.6%, according to that data we have right now, much less in India, 2.4. And the reason is because they have more relatively younger population and less elderly population above 65. Many studies done in the United States, 60% of the US population actually vulnerable to COVID-19. If you look at the cases per million, we're number two. We're just second to Chile. Peru is number three. Brazil number four. And I think now the virus is circulating very strong in South America, where it's supposedly be winter there. In Sweden, they got also a lot of death because they followed the herd immunity, which was a disastrous, led a lot of death without really providing the immunity they were hoping for. Actually, the serology testing, the antibody testing showed only 7.5% are immune, or they have antibodies. I would not say immune, but they have the antibodies. And so that's not obviously not enough, not even close to perform the herd immunity they were hoping for. If you see the cases per million also in Saudi Arabia is high, so they have a lot of infected people, but because also they have less elderly population, their fertility rate is down. So now if you look at the death per million, the Belgium, UK, Spain, and Italy, they had it really hard along with Sweden, and US is probably still top 7, 8 countries. This is a really important slide. I want to show you that the COVID-19 is working its way to be the number one cause of death on daily basis in the world. And WHO, the World Health Organization, reported today, July 24th, the highest number of COVID-19 new cases per day. Until now, the TB was number one killer in the world, like as an infectious disease. Um, and as you can see, the tuberculosis kills about 3,014 patients a day, compared with COVID-19 about 3,001 a day. And I think this number is just going to go way, way higher than that. And it's just a matter of days or weeks. Um, Comorbidity is a big factor for patients with COVID-19. The serious condition, the serious illness, and the death is significantly linked to the number of comorbid conditions. This is based on an Italian study early in the course of COVID-19, and they looked at the serious conditions present in those who have died, and they looked and they found if you have no condition, the risk of dying was 1%. If you have, I'm sorry, no conditions, risk is 1%. If you have one condition, 25%, two conditions, 26%, and if you have three conditions, the risk is about close to 50%. You should suspect COVID-19 in any patient who has a new onset fever or respiratory tract symptoms such as cough or dyspnea. Actually, there is a new survey for CDC done by CDC, and they found that fever, cough, shortness of breath, one of these symptoms is present for almost all the patients, about 96% to be precise. You should also consider it in patient who has a severe lower respiratory tract illness without any clear cause. Somebody presenting to the ER needing intubation, and there is no obvious cause, like there is no like a large pleural effusion or obvious CHF or something else to explain that presentation. Other symptoms, GI symptoms such as diarrhea, nausea, muscle ache, and smell or taste disturbances. Also, you have to consider it with the close contact with a confirmed or suspected case of COVID-19 within 14 days, whether that through work in healthcare settings or other type of work. So when we talk about the close contacts, include being within approximately 6 feet of the individual with COVID-19 for more than a few minutes while not wearing PPE. So we all, like in healthcare now, exposed to COVID-19 on daily basis in our unit, but we wear the PPE, and you know, some of us obviously when we do procedures we spend more than a few minutes, but that should not count. Now, also having direct contact with infections, secretions while not wearing PPE, that would be another possibility. So if you have one of these conditions, obviously you need to be tested. So testing may include either doing the PCR test, antigen test, or antibody test. The PCR test, it's a molecular test using the nucleic acid amplification, or NAAT. We call it RT-PCR test. And the way we do it through the upper airway using nasal or throat swab. There is also a new test where you can actually use a saliva. It may be really helpful, especially for kids and people who cannot do the other way of testing. Unfortunately, we have made some progress with this molecular test, but until now, many outpatient settings take more than a week sometimes to get the results, even like 5 months after the pandemic started. So that's challenging, but at the hospital, at least we get it within the same day or within 24 hours, I would say. The test is highly accurate and usually does not need to be repeated. There is probably small portion of patients we may have to repeat the PCR. If you really have very high suspicion, the patient is intubated, then you can send another sample from the bronchoalveolar lavage to be confirmed, as the PCR on the lavage is much more accurate. And if you have the test, if the test is positive, that means you really have the test. The false positive rate is very, I mean, it's almost unheard of. Now, some people say like, oh, I tested negative, then I tested positive again. Well, the test is not falsely positive, but sometimes the test can continue to be positive even after you stop being infectious, because you may continue to shed parts of the virus RNA, which may make the test positive. So the false negative rate, I would say, is very low, and in some tests maybe less than 10%. Other people think it's up to 15%, but I think to some degree it's reliable. The antigen test, on the other hand, is rapid diagnostic test. It's also can be done nasal or throat swab. It takes 1 hour or less. If it's positive, you have to take it at the face value. It is for sure positive, but negative results actually may need to be confirmed with the molecular test. The antibody test, on the other hand, it is a blood test done by finger stick or a blood draw. It takes between 1 to 3 days, and there are a lot of these antibodies tests. Unfortunately, some of them are not FDA approved or regulated, and I would want you to be very careful when you read these results, especially if they tell you that you have antibodies. Some of these tests don't differentiate whether these are against COVID-19 or other human coronaviruses, and also doesn't give you really the titer and whether these effective antibodies or not. So I want you to take that very carefully. And as we talked before, having the antibodies does not mean that you don't have the virus. It really depends on the time you were tested, whether you or may not have the virus. Again, this is to show you the difference between the molecular test, RT-PCR, and the antibody test. The sample is from nasopharyngeal versus blood. Then the blood was added to the device here where there are some antigen that will be connected to antibodies. If there are SARS-CoV-2 antibodies from the patient, it would show the test is positive. Here is you obtain the sample from the nasopharyngeal area, and then you put the swab inside the tube. You break the top part, you close the tube, and then you take it to the machine where it amplify by PCR, and the result will be read as positive or negative. The RT-PCR, or the nucleic acid amplification testing, is the most common one and the more reliable test actually for COVID-19. Again, if you have a positive results, it is positive. You don't need to do extra testing. If it is negative, in the other hand, and you have a very high suspicion for COVID-19, repeat the test within 24 to 48 hours. It's not recommended that you repeat the test within 24 hours. In patients with evidence of lower respiratory tract illness, you can obtain lower respiratory tract specimens such as bronchoalveolar lavage or bronchial wash, and that can be also sent to have RT-PCR testing. So in general, the sensitivity of the testing likely depends on the precise RT-PCR assay, the type of specimen. If you get it from lower respiratory tract is better than from upper respiratory tract. The quality of the specimen, the nurse or whoever took that sample, did they do a good job getting that sample, and the duration of the illness at the time of the testing. For example, it is very high in the early course of the illness, more than 90% on day 1 to 3 of the illness, less than 80% at day 6, and less than 50% at 14 days or after. We talked about that lower respiratory tract may have high viral load, and as a result, we will have a better results. Again, the bronchoalveolar lavage about 95%, sputum about 72%, oropharyngeal swab is the least. What about repositive? There was a Korean study about 285 COVID survivors who tested positive for coronavirus after their illness had apparently resolved. So this is the phenomenon called repositive. And what they found about this patient, they tried to culture the virus from all these patients, and none of them actually they couldn't grow the virus in any of their samples. So what it means that these patients continue to shed the virus after they recovered. I'm sorry, continue to shed part of the virus, the RNA of the virus, but they were not infectious. So in this situation, even though you're still having continuously positive tests, the fact that you're not contagious is confirmed in this study. Now, actually, the CDC now, they said there is no reason to retest you. So if you have, there are 10 days since you tested positive and you have 3 days free of symptoms, then you don't need to be tested again to finish your quarantine.
How about the risk of reinfection? Should I worry about catching COVID-19 twice? Well, we know that reinfection with SARS-CoV-2 has not yet been definitively confirmed in any recovered persons to date. And we know that also persons infected with endemic human coronavirus, they actually have immunity for almost 90 days. They don't become susceptible again for about 90 days after onset of infection. So if you have even positive PCR, let's say a couple of weeks after the patient got infected, or 3 weeks or 4 weeks, that does not mean the patient is infectious or contagious, most likely still shedding the virus. There are reports about these patients shedding the virus for an extended period of time, and that does not represent reinfection. So if the patient is still asymptomatic during this 90 days, even if the patient tests positive, you should not retest again anyway. And if the patient is scheduled for surgery and you postpone the surgery 10 days because you're worried, obviously, about catching the infection, after that 10 days or 14 days, whatever you choose, you do not have to retest the patient. So that's very important for pre-op evaluation. I know there is a high level of anxiety, especially with an anesthesiologist, about catching COVID-19. We do understand that, but the retesting these kind of patients, even if they are positive, that does not mean they are infectious, and I don't see the value of retesting, except really is going to increase the stress on the patient by keep postponing his procedure or her procedure. So now, if the patient who tested positive becomes symptomatic during the 90 days, these 90 days, and you cannot find any other alternative diagnosis, then this patient may need to be retested and isolated with consult with infectious disease. So only the exception, if you really have highly suspicious symptoms, you have no alternative diagnosis within the 90 days, then you can isolate the patient and get ID consult. From imaging standpoint, we know the primary features are of atypical pneumonia or organizing pneumonia. We see bilateral findings in about 85% of the patients, 33 to 86 predominantly peripheral, and 70 to 80% predominantly posterior.
So this is from UCLA chest X-ray COVID reporting classification. So if you have the typical findings, peripheral consolidation or ground glass opacities, multifocal rounded opacities, mostly peripheral and posterior, then this is classic, typical. Indeterminate when you have multifocal but non-peripheral consolidation. That would be intermediate. And then the atypical, like very less likely to be COVID-19, but you can still consider it. If you have a pleural effusion, that's not common with COVID-19. Atelectasis, adenopathy, focal lobar consolidation. These are stuff you may see it with more bacterial infection or other etiologies. Again, negative chest X-ray does not exclude COVID-19. This is one example of X-ray. You could see here the peripheral infiltrate in this patient. You see the center is clear, the periphery of the lung. So the CAT scan of the chest is much more sensitive than chest X-ray, but we should not use it as a first line or to screen patient for COVID-19. You could use it for looking for other etiologies or if you're suspecting PE. The ground glass opacities, usually they show up on the CAT scan relatively early, between days 0 to 4 of symptom onset, and they peak between 6 to 13 days. Lab findings, it is important to take a look at these labs, as they are not just important to make to help with the diagnosis, but also to give you more prognostic information, such as like a D-dimer above 1000. There are studies that suggest that we should consider full anticoagulation on patients with D-dimer above 2 to 3000. LDH usually above 245, CRP above 100, troponin above 2 times the normal, ferritin above 500, elevated CPK 2 times the normal. And there are studies actually now that if you have absolute lymphocyte count less than 800, you have a higher chance of being admitted to the ICU or even getting AKI, so acute kidney injury. In general, we recommend avoiding nebulized medications. We like to use MDI on these patients to avoid aerosolizing the virus. These are the stuff that we like to use. These are the stuff we don't like to use. So let's talk a little bit about pathophysiology. When the virus gets inside the alveolar cell, there is a cascade of events that would lead eventually to the infection, the pneumonia, and in some situations, maybe ARDS and cytokine storm. So normal gas exchange, as you guys know, this is a normal alveolar unit. You could see here type 1 alveolar cells. These are the main cells that are used in gas exchange. And then there is the type 2 cells, which are used in producing surfactant. And the advantage and the benefit of surfactant is keeping the alveolar unit open. If the surfactant is not there, the surface tension is gone and the unit will collapse. So when you get infected with COVID-19, the virus makes its way eventually to the alveolar units. Using its spike protein, the S protein, it will connect to the ACE2 receptors on the type 2 alveolar cells. And that would allow the RNA to go into the cell and hijack it and makes many copies of the virus. So let's review what happens at the alveolar level. After the infection, the virus makes its way to the type 2 alveolar cells, and that will cause the release of inflammatory signals, um, which by itself will cause recruitment of macrophages. Now, the macrophages will come to the area and will release cytokines, and these cytokines will cause vasodilation. So you have more vasodilation that would allow more immune cells to come in the site of injury and exit the capillary. The fluid then will start accumulating inside the alveolar units. That the fluid that is building up in the alveolar units is actually responsible for the ground glass opacities that we see on chest X-ray or CAT scan of the chest. So at this point, probably the patients start to have some shortness of breath, and some patients may come to the hospital with usually between day 7 to day 12. As the fluid build up inside the alveoli, that by itself will cause the destruction of the surfactant. And we know that surfactant is responsible to of the surface tension. Without it, the alveolar unit will start to collapse. And that is responsible for the patient's feeling of shortness of breath. Now, at this point, the patient has shortness of breath. There is increased work of breathing as more alveolar units are collapsing. The neutrophils now are recruited to the site of the infection and are releasing reactive oxygen species to destroy the infected cells. Unfortunately, the alveolar type 1, alveolar type 2 cells now are targeted, and they will be destroyed. As a result, you will obviously experience more shortness of breath and more hypoxia at this point. And that would probably start signaling progression to more ARDS. Now, if this process continues, there will be more damage, there will be more accumulation of dead cells and protein-rich fluid from vasodilation and capillary leak. And the whole unit, the whole alveolar unit now is completely filled with the high inflammatory fluid. And if you do the chest X-ray or CAT scan, you will see actually more consolidation at this point. Some of these inflammatory mediators would go to the bloodstream. There will be more vasodilation. There will be more like a septic shock type picture, and then multi-organ failure as well. So this is another way to look at it. So you have the virus here in yellow. The virus made it from the upper respiratory tract to the lower respiratory tract. You have the cilia here trying to push and get the virus under control. If you have, unfortunately, a higher viral load, in spite of your immune mechanism and mechanical ways of defense, some of the viruses, unfortunately, will make their way to the lower respiratory tract, to the alveolar unit. This is the normal alveolar unit now is infected, and the type 2 alveolar cells are infected. As a result, you have the vasodilation, you have the fluid is filling now the alveolar unit, which can present as ground glass opacities and viral pneumonia. And again, we're going to see in this CAT scan, again, you can see ground glass opacities. As you go down, you see in more posterior location and more peripheral location, more posterior and to some degree more peripheral location. This is a replication cycle for the COVID-19, the coronavirus, SARS-CoV-2. So when the virus comes to the cell, it attaches through the ACE2 receptor and the S spike protein, and using the fusion process endocytosis, it makes its way inside the cell. Uh, then through the process of uncoating, it would release its genomic RNA. The genomic RNA would hijack the ribosome and start the process of replication and translation. So it does translate itself into more mRNA and actually more other types of protein like S protein, E protein, M protein, etc. And then this process takes place on the rough ER, and then the RNA makes its way through the Golgi apparatus into the vesicle, and through the exocytosis, the new viruses will, new replication, new copies of the virus will be released again to infect more cells and continue this process. So this is another demonstration. This is a COVID-19 patient example, coughing, not wearing a mask, the droplet traveling, infecting this patient, this person who is not wearing a mask. The droplet that contains the virus make its way, and the viral now inside the upper respiratory tract, and then going to the lower respiratory tract, attaching to ACE receptor using the S spike, then with endocytosis, making its way into the cells. The using the this is the coronavirus, using the ribosomes, it hijacks that and use it for translation and making copies of itself. So you can see it's making copies of the RNA, and it makes copies of the different spikes protein, and then through the Golgi apparatus, it starts to accumulate the pieces, and then through the exocytosis, the new viral will be released. So the transmission route, as you guys know, the most common, the number one concern is droplet. And the droplets can happen if you talk, cough, sneeze, scream, sing. These things always happen if you are in proximity with other people and not wearing a mask. Uh, of course, you can have that through direct contact, such as shaking, kissing, hugging. Um, these are also responsible of some infections, and also indirect contact through surfaces. Like if you use the bathroom, using the elevators and other surfaces. Unfortunately, this virus has a chance to live and survive for extended period of time on different surfaces, on coins up to 4 hours, on plastic and steel for up to 72 hours, on hands for about 30 minutes, I'm sorry, on hands for several hours, and actually can be airborne in closed spaces up to 30 minutes and sometimes longer, on cardboard for up to 24 hours. The question, how much transmission happen from surfaces? I think honestly it's a modest risk for household spread based on this study from University of Bonn in Germany. They analyzed the air and various household surfaces for coronavirus in 21 German households in which at least 1% tested positive. None of the air samples actually tested positive for virus, and only 3.36% of all object sample tested positive. One thing that actually they noticed that 15% of the wastewater samples from the wash basin, showers, and toilet tested positive for the virus. It's not clear whether actually this is responsible of infecting other people or not. So as much as we do recommend cleaning the surfaces and making sure you sanitize and clean everything, especially if you have another person with COVID-19 in your household, the number one way of transmission is still and will be always a droplet. So airborne transmission, finally, WHO, the new guidelines, which was released in July 9, acknowledged that airborne transmission of COVID-19 in crowded indoor locations with poor ventilation cannot be ruled out. Cannot be ruled out. So the difference between droplet and airborne, remember droplet are large particles. They come with cough, sneeze, scream, sing, talk, and they can spread droplet of saliva and mucus. They are usually large, more than 5 microns. Airborne, they are tiny particles. They mostly produced by talking and actually can be suspended in the air for longer and travel even farther. They are usually less than 5 micron. To just give you an idea, the human hair is 60 to 120 micron wide. So it just gives you some idea how small the airborne particles. There are some reports of outbreak occurring in restaurants, choir practice, and fitness class, which suggested the possibility of airborne transmission. How about the spread from toilet? I told you about that study from Germany, 15% in the wastewater. In general, we do recommend, until we have further information, to close the lid when you flush the toilet. And honestly, keep your mask on even if you go inside the toilet. If you are using public restroom, even if there is no one inside it. When we talk about the R0 number, we're talking about the average number of people that one person with the virus can infect. For H1N1, this number is 1.2 to 1.6. Ebola 1.6 to 2, for COVID-19 is 2 to 2.5, which that is the reason which makes this very difficult to control, because of the number of people potentially one person can infect, and that makes a virus, when it's established in a community, exponentially start to spread and cause very large number of cases within a short time. We saw how we started with one case on January 19 in the United States, and now we're dealing with close to 4 million cases. And unfortunately, we're probably going to see much higher cases. And in fact, I think the real number of cases is probably maybe even 10 times the one that is reported. So think about it, 1% is infecting at least two, each one of them is infecting two, and then these two are infecting another two, so you start with 1, 2, 4, 8, 16, 32, and etc. So to understand the exponential growth of the virus, I'm going to tell you an old story. This is the story of the inventor of chess and an Indian king. As a reward for coming up with the game, the inventor um, asked to be paid according to a simple formula. Um, he'd get 1 grain of wheat for the first square, and then on a double on the second one, and so 2 for second, 4 for the third, and 8 for the fourth, and so on, with the number doubling each square through all the 64 squares in the chess set. Of course, the king laughed this off as a meager reward, but actually the real number was 18 odd quintillion grains of wheat, which is, not, obviously no one is able to bring that much wheat. So you can apply the same scenario for COVID-19. Most estimates put the doubling time for COVID-19 infections at a week or less. So, you could have 10,000 times as numerous as they are every few months. So if you are looking at whatever number you are now, actually the real number is going to jump much higher in just a few weeks. Actually, US added in the last 2 weeks almost a million cases. So I'm bringing here some statistics about the highest risk jobs in US right now. As you can see, the dental hygienist is 99.7 risk score. The respiratory therapist technician about 95%, dental assistant 92%. The general practitioner and family medicine is actually right there, very high. RT, X-ray technician. So these are all like people work with us, and we obviously we recommend like the highest level of protection for all of them in dealing with this difficult tasks. As you can see, the PAs, the internists, the physical therapists are all at also increased risk. If you really want to know, let's say you decide I'm gonna attend a wedding, or I'm gonna fly, or attend a game, concert, you want to calculate your risk, I recommend going to this website, COVID-19 risk.bios.gatech.edu. And you can actually put the number of circulating cases in the state or the city, and the type of event, how many people attending the event, and you can actually get estimate of the how much risk you have to acquire COVID-19 attending that event. It's really very nice tool. There is a lot of attention right now to the super spreading events. Some studies actually estimated that about 80% of the new cases that we see with COVID-19 are related to super spreading events like gathering, whether church or bar, or other just kind of people gathering. The super spreading events depend on multiple factors. Obviously, the larger the number of people, the higher chance that more people can be infected. Also, the duration, the longer a group stays in contact, the greater the risk that the virus will spread among them. The CDC requires at least 15 minutes for the contact tracing. Now, also what people are doing matters, like talking loud, screaming like in the bar, singing like in the parties or church or choir, breathing hard like in dance or gym, dance class or gym, not a yoga class, of course. And poor ventilation system is also a big factor. As we said before, this could be responsible for much of the new coronavirus transmission. So we'll give you some examples. Two symptomatic people attended church events March 6 to 8, later tested positive for COVID-19. At least 35 of 92 attendees acquired COVID-19 and 3 died. From contact with church cases, at least 26 additional cases were confirmed with 1 death. So we started with 2. We added 35 from the church from that day. These 35 transmitted the disease to 26. So you ended up 2 infecting about 61 and causing 4 deaths. That's a super spreader event. This is another example when after a choir practice with 1 symptomatic person, so 1 symptomatic person in that choir, that person actually was able to infect almost everyone. Almost 87 of group developed COVID-19. So this is the index case. These are the confirmed. This is the people who really did not have the illness. One thing about this pandemic, about the coronavirus, is how important to keep up with the science and with the changing approaches for treatment, prevention, and even for infection control. Initially, I think we were told that we have to do 2 tests 24 hours apart to make sure the patient can come out of isolation and go back to work or to the community. Well, now the CDC is using what you call symptom-based strategy for discontinuing the transmission precautions. Basically, if the patient has mild to moderate symptoms and not immunocompromised, not critically ill, at least 10 days since symptoms first appeared, and at least 24 hours have passed since last fever without using fever-reducing medications, and also symptoms, cough, shortness of breath, have improved. So 10 days since the first symptom, 24 hours since the last fever, and improvement in the symptoms. The patients who are not severely immunocompromised and not symptomatic, that transmission should discontinue, precaution should discontinued when at least 10 days since the patient tested positive with the PCR. So these are very important, especially when it comes to coming back to work, going back to school, also when maybe admitting to a long-term care facility, although most of the long-term care facilities still requiring the 2 negative PCR 24 hours apart, and I'm hoping this will change in the near future. So what if the patient is immunocompromised or has severe illness or critical illness? In this situation, you have to wait 20 days since symptoms first appeared and at least 24 hours since the last fever without using fever-reducing medications, and the symptoms such as cough, shortness of breath have improved. Now, this is a little bit tricky. So a lot of the critically ill patients, they still short of breath. They may have, like they may still be on the vent or on heated high flow nasal cannula. So we really need more clarification whether the fact that the patient is requiring less oxygen, the patient is requiring less support, does that qualify? And we'll review some literature where this change came from. Well, the rationale behind using symptom-based strategy is based on some literature. Actually, no report, we didn't find any report of viable SARS-CoV-2 detection in the respiratory specimen beyond day number 9 of after symptom onset, even if the PCR is positive. The high SARS-CoV-2 PCR cycle threshold, more than 34, and in one study more than 24, have not been found to have live virus in the respiratory secretions. So actually, the higher the PCR cycle threshold, the lower chance that you have virus detected or viable virus. So if you have the threshold like 34, 40, 38, extremely unlikely that you will have any viable virus. There is a study in Taiwan, included 100 patients with COVID-19 infections, and they studied also 2,761 close contacts, and the investigators found no secondary COVID-19 infection among the 852 contacts who were exposed after day number 5. So if these guys exposed after 5 days, they actually had 0 infection reported in these patients. I invite you to watch the second part, which will be focused on therapeutics, vaccination, and other important issues. Thank you.